Good morning and welcome to the Sickle Cell Society's podcast about the COVID-19 vaccine. Now, we've all seen on social media the various adverse comments from some in the Black and Brown community about the vaccine. We're here this morning with clinicians and patients from across the country to help dispel some of the myths that are going around about the vaccine. Now, clearly, there have been injustices in the past about experimentation and vaccines, but actually, it's really important that this vaccine is taken to address this dreadful and awful COVID-19 pandemic. I will say no more because people can make their own choices, but what we hope will happen today is that you'll hear questions from people who have anxieties, people who might be worried and want more information. So we hope today will help give more information to enable people to better understand the vaccine and protect themselves from this dreadful pandemic. So that's all from me. And as we go through the podcast, individuals who will be talking will introduce themselves. Thank you very much.
Thank you, John. So my name is Rachel Kesse-Adu. I'm one of the sickle consultants in one of the London hospitals. We think we have the biggest sickle population, but there are others who also claim the same. So my job today is essentially to share some data about how COVID has impacted the sickle community. I'm going to share some slides now. So essentially what happened with care for sickle and other hemoglobinopathies in the UK last year was we got separated into blocks known as hemoglobinopathy coordinating centres. There are 10 sickle coordinating centres which cover all the regions in England. And that was actually quite timely because once this pandemic started last year, one of the things we did quite quickly was have people from each of the coordinating centres join a weekly call. And one of the things we did was start collecting data on how our patients were doing, because we thought COVID was going to be bad for sickle patients, but obviously at the start we didn't know. We just had a bit of information from Italy and a bit of information from the US. So what we did was once a week, every week, each center would collect data on any patients they had admitted with the COVID-19 infection patients or patients they had in the community, and it all got pulled into one data set, which is managed by Dr. Mark Layton, who is a senior clinician at the Hammersmith Hospital. And we formed a group who are nominally hemoglobinopathy research clinicians who meet once a week to review this data. So this slide shows you what our numbers have looked like since the start of the pandemic. So we started collecting this data back in April, and you can see from the blogs, week on week, there's been an inexorable rise in the numbers, and these numbers go until last week. We think of the pandemic in two waves. The first wave is thought to be from about February last year till August, and then the second wave started in September. So at the end of the first wave, there had been 250 sickle patients who had been affected by COVID, and as of last week, that total number has gone up to 555. So this gives you an idea of the hemoglobinopathy coordinating centres. So the highest number, it will come as no surprise to anyone, are from the centres in London. So the South East, which includes Guy's and King's as the two big centres, and then our regional district generals, has the highest number at almost 200 patients. And then East London has the next highest number. But you can see every single coordinating centre does report patients with COVID right through to Bristol. This slide hopefully gives you some idea of what the admissions are like. So this refers to the current situation. Of the total population of sickle patients who've had COVID, 47, this is in the second wave, 47% have needed admission to hospital to have their condition managed. But you can see, a fair few have also managed their COVID at home, not requiring any medical input. The number looks slightly different in the first wave, but that probably is affected by the fact that in the first wave, if you were managing your COVID at home, you were not having a swab. So the numbers in the first wave are probably not truly representative. Of our adult patients, just over 30% who end up with a COVID infection end up not only needing admission, but needing transfusion when they come into hospital. So that's a fairly significant proportion of our patients who've been admitted with COVID. In the children, COVID is definitely milder. It reflects exactly what happens in the non-sickle population. So fewer children are admitted and fewer children have needed transfusion once admitted. And this is probably the slide I would hope everyone understands, because it tells us that COVID is a significant ailment in sickle patients. So this is in the second wave. The blue bar shows you people who've had COVID, recovered, and don't have COVID anymore. The orange bar shows you patients who we currently have admitted to hospital with COVID. And this black bar here shows you within the second wave patients who have sadly passed on because of COVID. And you can see in the first wave we had people who passed on because of COVID. So these are patients with sickle cell who were admitted with COVID-19 and did not survive because of the infection. The numbers look slightly worse in the first wave. Again, there are lots of factors that affect that. Partly the second wave is not over, it's still ongoing, but also in the first wave, there was a lot of rapid learning that had to happen. So the way we managed COVID in the first wave versus the second wave is really quite different. It's important to note that no one under the age of 18 has died from COVID. All our patients who've passed on from COVID have all been adult patients. And the most important thing for me as one of the sickle doctors managing sickle patients with COVID is to note that how COVID affects our sickle population is the same as it does the non-sickle population, with one slight caveat. So everyone knows that children get COVID, it seems to be a mild illness in them, they carry on their business, recover, no problems. And you can see from the age distribution here, all the way up until this age group between 40 and 49, the numbers of people who have passed on from COVID are really quite little. But the minute you hit age 50, that number goes up quite significantly, and it holds true beyond 50. So in the general population, the risk, age of risk is thought to be 70, but within the sickle population, we think that the age, where age on its own becomes a risk factor for the COVID infection, is age 50. That's all I wanted to share. What I'm hoping these slides have done is help make the case for why the vaccine is essential. COVID is not a mild illness in a sickle patient. It's not always just a cold or a flu. So the rationale behind us. So first of all, sickle patients are clinically extremely vulnerable, and we think our data bears that to be true. Based on that categorization, sickle patients are going to be offered the vaccination much earlier than the non-vulnerable group, and that is absolutely the right thing to do. The COVID vaccine has been taken by quite a number of sickle patients now. And the good thing is everyone who's had it is happy to speak on their experience to other people to try and encourage more people to have it. The vaccine doesn't mean, doesn't offer you 100% protection. It doesn't mean you will not get COVID ever, but the hope is that even if you do end up with infection, it's going to be mild, and you're not going to end up needing admission, hopefully, or any of the other extra therapies. So we're really, really encouraging our patients to please look at the data for yourself, make a decision for yourself, and try not to be too influenced by external factors. Make decisions for your health in your own best health interest. Okay, I'm going to stop and hand over to Abbie now.
Thanks, Rachel. Hi, everyone. My name is Abbie. I'm one of the clinical psychologists that works in the haematology team with Rachel at Guy's Hospital. So I'm going to speak briefly to you today about some tips, techniques, ideas, strategies in making difficult decisions about your health. This is something that we often are asked to support patients in our department with. So I'm hoping some of the things I can share today might be of use to you in making this particular decision. So I think the first thing to say about making decisions about your health is just to acknowledge that it can be really, really tough thing to do. Some decisions might feel easier than others. There might be some choices with your health that you've had a gut feeling that's the right thing to do, and some that you find yourself thinking over a little bit more and feeling more uncertain. Everyone has different ways that they make decisions, but I'm hoping today some of the ideas that I talk about you might think are helpful and take on for yourselves, particularly if you're feeling unsure about whether you want the vaccine or not. It's really normal to feel conflicted about important decisions. And as I said, we see a lot of patients in our department that just need a bit of help thinking through and finding ways to make that choice. And it's good to acknowledge that often there's really no right decision to make, and the choice that you end up making is based on your own personal experiences, values, and what matters to you as an individual. So the first thing that I would recommend when making any decision about your health is to manage any difficult emotions that you notice come up. So when our health or our safety feel at risk in some way, it's really natural that we're going to get a lot of strong feelings like fear, anxiety, anger. We might feel confused or sad. And when those emotions become quite intense, it can make it harder for our brain to think through problems and make sense of information. So if you notice yourself feeling some of these emotions when you think about whether or not you'd like the vaccine, it might be helpful to think about using some techniques that might reduce some of these emotions, so it's a little bit easier for you to think through the choice you have to make. So there's different techniques that can help with this. There's breathing exercises, and I've got a brief diagram there, but there's also a link where you can listen to some audio that talks you through. There's muscle exercises that are really good in bringing down anxiety and fear. And there's some self-soothing exercises as well, where we use the 5 senses to try and calm and relax our emotions. The next thing I'd recommend to do is to actually list down all the options you have. And a lot of people find it quite helpful when you've got to make a big decision like this, is actually to write down the information you know, rather than relying on yourself to just think it through in your head. So you might find it helpful to list your options in a table a bit like this. The next thing that might be helpful to do is think about what information you already know that relates to the choice you have to make, and then ask yourself where this information is actually from. Because we have things like internet and social media at our fingertips, it's really easy to get a great deal of information about any topic we like really quite quickly. The difficulty is that we often don't know where that information has come from. So we don't know whether those sources are reliable, whether they're related to fact or science, or whether this is someone's opinion or feelings about something. So ask yourself those questions about what information you do know. Where have you got it from? Who has told you? What does that person know? Is that likely to represent what they feel, or is it likely to represent some kind of fact that they've obtained? Often we tend to speak through difficult decisions with other people. We find it quite helpful to get their advice, their support, their opinions, but it's always useful to ask those same questions about where that other person is coming from. Where have they got their information? Is that likely to be a reliable source, or may they have got this from social media or the internet, somewhere you may not know where it's come from? So I spoke to some of the consultants in our department, and there's a list of sources of information that they would consider quite reliable when gathering information to make your decision about the COVID vaccine. So these can include speaking to the health professionals that are involved in your care, looking on NHS or government websites, and any resources that you might find on the Sickle Cell Society or through STSCN. Once you have a good amount of information that you feel quite confident is from reliable sources, it might be helpful to then outline what are all the risks and benefits of each of the options you have. So thinking about what are the positive elements of each option, what can you gain from them? And then thinking about what are the downsides or the dangers of each option. And when you're thinking about the risks and benefits, it can be helpful to try and cover a range of different areas. So think about the risks and benefits in your physical health, mental health, your social life, employment, education, finances, anything that feels relevant to the decision you're making. You might want to lay it out in a table a bit like we've done here. The next thing you might want to think about is, what don't you know? Are there any areas of information that you're unsure about? Do you have any unanswered questions that would help you make your decision? And think about what reliable sources you know of where you could obtain this information. And when you have it, add it to your risk and benefit list. The next thing to do when you feel you have a pretty comprehensive list of risk and benefits for all of your options is to sit down and compare these lists to help you make your final decision. Looking at the list, you might notice that some options have overwhelmingly more risks than benefits, and that might feel like a good reason to exclude that option from your choice. Some people also find that certain risks and benefits matter more to us as individuals than others do. So you might find it helpful to add an importance score to each of the risks and benefits you have listed, with lower scores meaning perhaps they're less important to you and higher scores meaning they're more important to you. And then what you might want to do is add these up and see, are there any options that have really high benefit scores and lower risk scores? And that might indicate to you this might be the right option for you. Once you've decided what looks like the best option based on the risks and benefits, you might want to give yourself a cooling off period if immediate action isn't needed. So giving yourself a little bit of time to sit with the decision you've made to make sure that it is the best one for you. In this time, you might find that you have more questions pop in your mind. You might find that you come across more information that you can add to your list. This may or may not change your final decision. And you might find that you feel more or less comfortable with your decision as time passes and you settle with it. And that might give you a clue as to whether this is something you definitely want to go forward with or not. A few things to remember when making difficult decisions. There's no such thing as a risk-free choice. So often when we're looking for what option we should go for in any decision or problem we have in life, we try to look for the one that feels the safest or the best. But the reality is there isn't one that excludes any risk. And it's normal to feel conflicted with your choices, even when you've made your final decision. Uncertainty exists in everything we do, and often that's where we often feel uncomfortable if we can't 100% guarantee that the choice we have is the right one. The best decision for you may still feel quite uncomfortable. It's also worth acknowledging that inaction is actually action. It's still a choice. So I think some people feel that if they opt out of the vaccine, it eliminates any risk that might be associated with it, but it doesn't eliminate the risk of catching COVID-19 itself. So it's important to remember that there isn't a way to opt out of this decision. You still have to make a choice. It's also important to recognise that making decisions alone are really difficult, and you might find it helpful to make sure that there's somebody that you trust that you can talk this through with. This might be someone you know, or it might be health professionals that you work with. It's good to think about who has reliable information that can help you with this. And finally, other people may have a really strong view about what is right for you, and you might take their opinions on board, but it doesn't mean you have to follow their advice. It's important to recognise that this is your choice about your health, and hopefully some of these ideas will help you to make the choice that is right for you as an individual. That's all I have for today. Hopefully some of those ideas are helpful. We've done it super brief so as not to keep people too long.
So yeah, I'm Zainab and I am a sickle cell patient, so I've got HBSS. I'm based in Birmingham at the moment, but normally before COVID, before I had to start shielding, I was in London, and I work for NHS England in policy. Thank you both, that was really helpful, just really useful information, so thank you. One of my questions is that there's been quite a lot of information online telling people to avoid the vaccine if they have a weakened immune system, whether that's because of medication or HIV, for example. Does that mean people on hydroxycarbamide should not have the vaccine?
So I'll take that. So even patients on bone marrow suppressing chemotherapy are being encouraged to have the vaccine. No, we are absolutely encouraging everyone, whether you're on transfusions, hydroxycarbamide, whatever treatment you're on, to have the vaccine. Hydroxycarbamide is actually not particularly immune suppressing. So some sickle patients will have additional conditions like lupus, for which they're on additional immunosuppressants. Everyone is having the vaccine because the fact that you're on Hydrea usually means you've got severe phenotype sickle anyway. If you're on additional immunosuppressants, you probably have additional conditions. So actually your need for the vaccine is probably higher rather than lower. So absolutely encouraging everyone to have it.
Hello, yes, I'm Lynette, and I am a carer or a mum of 2 children with sickle cell, and we're based in Birmingham. Sickle SC, they both have, they're aged 17 and 15. Given the sometimes varied nature of sickle crises in different individuals, is there a likelihood that someone who experiences crises more of the time than not could be at higher risk if they have the vaccine in terms of reactions or side effects not being picked up?
So no, I probably didn't share that there is a slide that looks at the infections in sickle patients, and actually whether you had mild or mild spectrum sickle disease or severe spectrum sickle disease does not make a difference to how the infection affects you. And the same is true of vaccinations. A bit like when we get the flu vaccine each year, some people will get a slightly achy arm and then that's it, there's nothing. Some people will tell you after the flu vaccine they have to take to their beds for a couple of days, and how your sickle behaves seems to have no impact on that. I think it's just how your immune system responds to the particular vaccine you're having. Even with this COVID vaccine, amongst my colleagues here at work, we've all experienced really different levels of reaction. I had a mildly sore arm after the second one. I think I woke up about 2 o'clock and I felt a little bit achy, and then that was it. One of my other colleagues, literally had to take paracetamol and some ibuprofen the next morning. It's so variable, honestly. I don't think your sickle predicts how you're going to react at all.
Okay, thank you.
Kojo, I'm a sickle cell sufferer. I have HBSS, and I'm a university student. So this is kind of a two-part question. The first is, what is the likelihood of the vaccine bringing on a sickle cell crisis in the patient? And what other protective measures are being implemented to help safeguard or protect against COVID-19?
So the reality is everything with COVID is new. We learn as we go along. Of all the patients who've had the vaccine so far, and we've had quite a few patients who've had it, no one's come in with a crisis. We wouldn't expect anyone to, because sickle patients probably have more vaccines than most other patient groups because of the lack of a spleen. So you get pneumovax, you get your flu vaccine, Hep B, Hib, meningitis. There's a whole bunch of vaccines that sickle patients have. And we don't, as a rule, have people admitted after vaccines with reactions. So we wouldn't expect it to be any different with this one. But all I can say is, of the patients who've had the vaccine till now, no one has come in with a crisis. Yeah. And then the second part about what is being done to reduce infection. I mean, it's the stuff that the government keep announcing all the time. So avoid crowds. When there's a lockdown and you can shield, please do so. Minimize your contacts. If you're out, wear a mask. Don't touch your face. What is it? Face mask. I can't remember the third one.
Hands.
Hands, that's it. Face mask and hands. Yeah, so yeah, wash your hands quite regularly. The standard things apply to everyone essentially.
Hi, my name's Laurel Broomont Palmer, and I suffer from SS. I'm 57 years old. First of all, I'd like to say that that presentation slide that Rachel did was amazing, because to be quite honest, it reassured me as a patient. It reassured me 100%. I hadn't seen it before, and I have to firstly say that that was very, very informative, and even put my mind a lot more at ease to how I felt before. My question is, I understand that there are 2 vaccines at the moment available, the Pfizer and the Oxford. Is there a recommendation for which one a sickle cell sufferer should take, or are they both equally the same?
So no, there are no vaccinations. It literally is. Our advice is just take what you're offered, basically. What seems to be the rule of thumb generally is if you're offered in the community, you seem to on average get the Oxford vaccine, and if you're offered on a hospital site, you seem to get the Pfizer vaccine. And I think that's just because of the storage requirements for the different vaccines, because one of them needs super cold temperatures and the other one can be stored at sort of room temperature.
Is that the only difference between them?
Well, so I think the storage is what makes a difference between how they're what you get offered where. Although one of my patients was just telling me, I think even a guy's, she was saying guys you get Pfizer and at Tommy's you get Oxford. The reality is, in the end, the effect of the vaccines is for you to make antibodies against a specific part of the COVID, the SARS-CoV-2 virus. So if you get the infection, your body's already got armamentum to fight the infection. The actual structure of the viruses is very slightly different as well. So the Oxford one is very much the way we think of viruses. So they take a bit of a virus, a whole virus, not the COVID virus. So in this case, they use a virus called the adenovirus. They attenuate it so it can't cause infection. And then they put a little bit of the mRNA from the COVID virus into the adenovirus. And then they give you that as the vaccine. So what happens is that bit of mRNA from the COVID virus means that you make the spike protein. So your body recognizes that as the foreign bit of virus and makes the antibody. It's not a whole virus. They don't give you a whole COVID virus. Whereas the Moderna and the Pfizer vaccines have the mRNA in a lipid bubble. So it's not within a virus shell, basically. So the structure of the viruses are different, but the effect on your immune system and your immune response is ultimately the same thing. You make antibodies and you have a T cell response. So if you should get infected, you've already got an immune response waiting for the virus, essentially.
Okay, thank you very much.
Sorry. Oh, and the slides, I can't take credit for them. So the slides, I mean, at the moment we have our updates once a month. They're actually Dr. Layton's slides.
They were brilliant.
Yeah, and so what we're hoping to do is two of our colleagues, Dr. Subhana Chakravorty and Dr. Noemi Roy, are going to take the information I've presented here and make something called an infographic, which will be on the Sickle Society's website
Excellent.
at some point, so everyone knows what the data is. There is an old one, Matthew, I don't know, Matthew and John, if it's on the website, the infographic from the data set, I think up until May there was, or June, but it just needs updating.
Yeah, I can't be sure, but the new one that Naomi and Sabana are working on will be on the website when it's finished.
Okay, thank you.
Excellent. So if we go back to the top of the order, so Zainab, if you'd like to ask your next question.
Yeah, I've got two, if that's okay. So the first one's around shielding. So once you've had the vaccine, does that mean you no longer have to shield? And the second one is around the variants. So once you've had the vaccine, does that mean that protects you against all of the COVID variants, or will you continue having to have different vaccines in the future?
Excellent questions. The true answer to all of them is I don't know. Right. So at the moment, the advice is once we've had the vaccine, it makes no changes to our behavior. One hopes that once enough of us are vaccinated and the viral rates go down, the advice should change. But at the moment, having had your vaccine, there is the advice to what you do every day is no different. So if you're in shielding, you continue to shield. When we open up, you continue to take the same protections you did before. Now, the question about the variants. So I know Moderna have come out and said that their vaccine is definitely active against the variants that have come through from Brazil or South Africa and the UK. And the other two haven't said anything, but we hope that the vaccines are active against them, because it's still an immune response to a virus that hasn't changed out of all recognition. So we hope that it still it will have effects, but I can't say for definite. Yeah.
My next question follows on from what Zainab just asked, which is around the protection, shielding, after having had the vaccine. In prioritizing sickle patients, has thought been given to the families of those patients? Because obviously if they're still continuing to shield and be careful, and their other family members coming in and out, and so on, how is it a matter of prioritizing sickle patients only, or is it sickle patients and their families?
So I have to look into this into some detail, but this question actually came up for the first time yesterday from one of my other patients. So he lives with his wife, who is his carer full time, and he actually sent us some data that seemed to suggest that carers would be prioritized as well. So he managed to, his wife, who would otherwise not qualify for the vaccine, did get vaccinated with him yesterday. I don't know the full detail of it, but there seems to be some prioritization for primary carers. There seems to be. Yeah, I will look into that a bit more. Maybe we'll put some more information out on that. Yeah.
Thank you.
I know as well that the Sickle Cell Thalassemia All-Party Parliamentary Group have just done a report on COVID, and that's one of the things they're looking at is, are carers getting vaccinated at the same time as people with sickle cell? So that's something I think they're looking into as well. Excellent. So if we can then have the next question from Kojo, that'd be great.
For people who just suffer from sickle cell trait and not the disease, I wanted to know kind of what is the extent or severity in patients who do contract the COVID virus or don't have the full-blown sickle cell disease. Are they still as much as risk as we are on patients who have the full-blown disease, or does the disease present itself slightly more similarly to patients who don't suffer from sickle cell at all?
Excellent. So we have not been collecting data on sickle trait patients, largely because no one really follows sickle trait, because we think of them as being non-sickle essentially. I know occasional people with trait say they get pain and a couple of other symptoms, but they don't get admitted and don't run into any of the organ complications that we see in our sickle patients. And certainly from the data to hand, they would seem to COVID appears to affect them no different than this non-sickle population. There are case reports here and there of a trait patient who's ended up in ITU, but we never think the trait itself has played a role in that. We think it's just a case of sometimes COVID is a bit severe. So we don't think trait's a particular problem, no.
And the question was from a lady in her early 30s who said that if you are pregnant and have sickle cell or are breastfeeding, so you've had it, but are breastfeeding, should you take the vaccine?
So certainly for pregnant women, the vaccine is being advocated. All sickle women who are pregnant should be being managed in a high-risk clinic, which means they'd see a clinician once a month. So that's quite an easy discussion to have during your appointments, and they can take your particular situation into consideration. But at the moment, the advice for pregnant women is to have it. I can't recall what the advice is for breastfeeding. I can't imagine it'd be any different. But just speak to your clinician if you're in any slightly unique situations. Pregnancy, definitely yes. Breastfeeding, I'm not sure. I think so. Yeah.
How many has any sickle cell patients been vaccinated as yet? Has there been quite a lot already?
Yes, a fair few, yeah. And we have no way of keeping an eye on the numbers because the sources of vaccination are at GP or hospital. So the ones who've had it with us, we know. But a few people, like today, I was saying I went into the day unit to see our transfusion patients to have the chat about the vaccine, and one of the ladies was like, "Oh, I had it last week with my GP." So yeah, so a few people have had, and we've had a couple of emails through from people who've had it with their GPs as well. So
and they've been all okay.
Yeah.
Brilliant.
Yeah,
thank you.
Yeah, the most pleasing one I had is one of our older sickle patients who's in her 80s just sent an email last night, which was really pleasing to see.
Brilliant. Yeah, that's fantastic.
And we'll be putting out a video as well with someone who's had the vaccine to discuss about their experience of it as well. That'll be coming out later on this week, hopefully. Lynette, I think you had a question.
Yeah, just about the priority groups. It's sort of two questions actually. One is to do with priority groups and where we hear about 1, 2, 3, 4. I'm not quite sure where the sickle patients sit in the rankings. And my other question is to do with my two children who are, one is going to be 18 in a couple of months, and the other one is going to be 16. But I think we've heard that children or under 18s are not being given the vaccine. So what about somebody who's on the cusp of being an adult, like my daughter? Obviously, we haven't heard anything about them having it because of their age. So I don't know what the policy is for sickle patients.
So it is a little bit arbitrary, isn't it? Once you're 18, you're an adult and you go into category 4, which is a CEV group, and you will get offered the vaccine. Below 18, between 16 and 18 is a little bit more grey, but anyone who's shielding is going to get offered the vaccine. But most children have been taken off the shielding list. So people 16 and under, most of them are off the shielding list and they're just carrying about their business. So children probably won't get offered it till they hit category 6. So that's in probably March and beyond. But your daughter, who's almost going to be 18, if she's within an adult service, will probably be offered it shortly.
Also, would that come when you say an adult service? The hospital that she's under should be
or her GP,
or the GP,
or the GP. Yeah.
Right.
It's really quite arbitrary. On the whole, we worry about the young people just so much less. They honestly, COVID is not a huge problem in the young people at all. With the whole shielding conversations that we had, and John can attest to this, the pediatricians were not super keen on it because of the effect on schooling, and then because children are just not that badly affected. Whereas the adult experience is just so different. We were quite keen that the adults did shield, particularly ones who were had additional risks and were of a certain age thresholds. So the same conversation is sort of grumbling through the vaccination conversation, because the idea is if someone is shielding, they should get offered vaccine because they are clearly high risk if they're still shielding. But if someone is not shielding, so anyone who's been taken off the shielding list just carries on till they get to the category 6 guys. I don't know if John wants to add anything to that.
Yeah, no, I agree, Rachel, and thank you very much. The only thing I would say, Lynette, is because your daughter, who's on the cusp of being 18, if you haven't had that conversation with the clinicians at the hospital in Birmingham, have it as soon as possible, if not the GP.
Right, yes, will do. Thank you.
Yeah, sorry. So my question is, we talked a bit about how COVID affects sickle cell patients in the kind of the 18 and under range, and how young kids aren't really affected. But what about my question is kind of, do you have the data or the statistics for how the young adults who suffer from sickle cell are affected? Because I'm 22 myself, so I'm a bit far removed from the young kids, but not quite in any other age range that has been previously discussed. And I think there are also a lot of people in my position who kind of wonder if they contract the COVID virus, according to statistics or previous statistics or data, what is the likelihood of severe illness or for them to recover completely without any sort of complications?
So I don't know if you remember the slides I shared. So certainly the risk in sickle adults goes up significantly at age 50, definitely. Below 50 and up until 18, it's sort of one expects, as it does in the normal population, it goes up in small amounts of increments. We certainly have people in their late teens, early 20s who've managed their COVID at home. We've certainly admitted people in that age group with COVID to the hospital and exchanged a few of them, transfused a few of them. So I can't say that just because you're 22, it's not going to be an issue. You're 22 with an underlying condition. So I would treat it as a high risk condition. But it's been quite reassuring that we've had a few people who've just called us and said, oh, my housemate had a positive swab, I've got a positive swab, but I'm absolutely fine. But on the other end of the spectrum, we have admitted people and had to manage them as well. So I think the risk is definitely less the younger you are. The risk is definitely more the older you are, but the risk is not absent just because you're 22.
Thank you.
I just wanted to ask us, if somebody's sickling, say, in their chest, and obviously we've heard about the COVID thing being about breathing and so on, is that a higher sort of, I don't know if risk is the word, but should one be more concerned if they're already having problems in that area? My daughter's sort of sickling round the clock, really. She's very seldom without pain. And she's in crisis at the moment, and she's having chest pain and so on and so forth. We are obviously in lockdown, but should she be in that situation and going into school again, should we be being particularly careful? Because
I would talk to your local team. So one of the things that the sickle centers have all struggled with is we've been quite keen for sickle patients to call us rather than 111 when they have symptoms, just because sickle is just so unique. So there are things that 111 might say, actually, you're fine to do that at home. But if you call your sickle center, they'll be like, no, come in. We want to see you ourselves. Because there are nuances to managing sickle, particularly because of the chest symptoms that our patients can get. And oxygen levels mean very different things in sickle patients than a non-sickle patient. So a non-sickle patient with COVID, can be managed in the community with oxygen saturations of 92%. We wouldn't do that for a sickle patient just because of the additional risks of sickling. So I think my main advice would be, if ever you're not sure, just call your sickle nurse, call your sickle center, have a conversation with them. And there is almost no sickle center that doesn't have hematology cover, even if it's not specifically sickle cover out of hours. So there'll always be someone to have a phone conversation with about what the best thing is to do. 111 it's not suited for a condition like sickle. It just it just isn't.
Okay. And is it a good idea to have those, what they call oximeters?
Yeah. Lots of my patients have them. I think they're grand. Because it adds to the conversation. You don't have to, because that's what hospitals are there for, and you come and we will check your sats for you. But if you had one and it was reading, 93, 94, it gives more urgency. And it's like, no, definitely come in. And if you had one and it was reading 98, you're a bit more relaxed. 98 to 100%, you're a bit more relaxed. But you would still need to have the conversation, because there are other symptoms that matter as well. So, but
you can buy those off the shelf. It doesn't matter which one you buy.
Amazing. I have a whole bunch of them. And quite a few of my patients who have had chest crises before, because our specialist nurses carry those ones, the ones that you can get off Amazon, have actually bought their own. And sometimes when we do the ward round, they'll do their own, compare their own to what we're doing, just to get an idea. I mean, it's difficult because I don't know how well vetted they are, but they give you some idea. So and certainly my family, when a couple of our households had COVID, we got them SATs to check, and it helped people relax a bit when their reading was quite high. But speak to your center, run through your symptoms. If you don't feel great, shove yourself into a hospital and get the proper assessments done.
Thank you.
Excellent. Any final questions? Okay, well, if there are any further questions, then feel free to get in touch. And we'll be putting all this information on our website, this video, and the infographic that was mentioned, and any further sort of data and information that comes along, we'll be putting it on our page. But thank you guys for coming along.
Excellent, thank you. And I'll plug Dr. Goodman's video. Please watch it. It's very good.
Yeah.
Very good. Excellent. Thank you.
Thank you so much. Thank you all.
Thanks.
Thank you. Bye.
Thank you.